All right. Well, good morning, everyone. I just wanted to welcome you to this year's fourth and final presentation of our 2025 speaker series. I wanted to thank everyone who's here and thank our valuable industry partners for joining our event. The Nebraska Oncology Society would not be able to meet its mission without their partnership. Here is our agenda for today. So we'll have two speakers today. And just a couple of housekeeping items. Just ask everyone to please keep their cell phones muted. We will have time for a question and answer period. And I do have a microphone, even if you are loud enough. It just helps us with the recording afterwards. So I'll go by with the microphone during Q&A. And the session is being recorded and will be uploaded to our event website for future review. There is continuing education credits for both of the speakers, and those links are already available on our website. Here are just some disclosure items. And then for our first our first speaker, will feature Dr. Deborah Doroshow with a presentation on antibody drug conjugates in non-small cell lung cancer. Dr. Doroshow is an associate professor of medicine at the Tisch Cancer Institute, where she splits her work between the early phase trials unit and the Center for Thoracic Oncology. She leads and oversees phase 1 and 2 trials of novel cancer therapies and provides specialized care for patients with lung cancer. Her research focuses on targeted therapies and innovative approaches to DNA damage and repair. Dr. Doroshow is also dedicated to improving the patient experience on early phase trials and ensuring complex treatments are communicated in a clear, accessible language. She completed her medical training at Harvard Medical School and Yale, and also holds a PhD in the history of medicine, enriching her work with insights into the human experience of illness. Welcome, Dr. Doroshow.
Trying it. Oh, I'm very loud. Okay. I'm going to do a lot of talking, so I am putting my drink over here. Excellent. Yeah. I'm so delighted to be here. I'm going to stand over here, otherwise you won't see my head. This is my first time in Nebraska, and it's been lovely. Can I ask before I get started how many clinicians of any kind I have in the room? Fabulous. Um, I see you, and I'm going to be asking for just a little bit of participation as we go through the day. Thank you. So today we're going to be talking about antibody drug conjugates in HER2 altered non-small cell lung cancer. These are my disclosures. All right, this is how you can get credit for participating today. We're supported by AZ and Daiichi, although I will say the slides were made by myself and my colleague, who are both experts in this area, without their input. Our learning objectives, so we're going to learn how to differentiate the different forms of HER2 alterations in non-small cell lung cancer, including mutations, amplifications, and protein overexpression. We're going to talk about how to apply multidisciplinary strategies to improve testing, which has its own complex issues alongside it. Think about how to incorporate the latest evidence into multidisciplinary care for patients with HER2 altered advanced non-small cell lung cancer, to formulate individualized treatment plans for these patients. And really, another focus here is going to be on how to identify and manage adverse events associated with some of these medications. So I'll just briefly say, because it is Lung Cancer Awareness Month, and I am a thoracic oncologist, that lung cancer is unfortunately one of the deadliest cancers that we have, and actually kills way more women than breast cancer. But we have a lot of good news. The reason I went into thoracic oncology is because things are getting better. We actually have a 5-year survival rate that is climbing every year because we have new therapies being developed all the time, some of which I'll discuss with you today. So I just want to take a moment to think about biomarkers in non-small cell lung cancer. Of course, we know that a good chunk of patients with adenocarcinoma actually have targetable alterations. The most common, of course, being KRAS in that lime green on the left, but certainly many, many different biomarkers that are targetable, including biomarkers we find in both patients who have smoked and those who have not smoked, making it really essential to test all patients. In squamous cell carcinoma, you can see that there are a number of patients who have an identified driver mutation. Many of these are not yet targetable, although one thing I'll notice is that the more I do this, the more I find unexpected mutations in patients with squamous cell carcinoma, especially mutations that can be found primarily in adenocarcinoma, and these patients do benefit from targeted therapies. So I really stress doing next generation sequencing in all of our patients. When we think about PD-L1 expression, one of our other key biomarkers, it's really sort of a third, a third, a third when we think about PD-L1 negative, PD-L1 low, and PD-L1 high patients above 50%. So biomarkers are incredibly, incredibly important. My colleagues at Penn did this lovely study where they looked at patients who had availability of genomic testing results before starting first-line therapy. And you can see in this Kaplan-Meier curve that the patients who had those results available lived significantly longer. So hard to overemphasize the importance of this testing. So let's talk about HER2. So here is a very busy pie chart looking at non-small cell lung cancer, specifically non-squamous disease. And you can see in those tiny little red rectangles that we have HER2 mutations, which comprise about 2% of non-small cell lung cancer, HER2 amplifications, which comprise about 1.4%. One thing I'm going to stress over and over again is that when we see a next generation sequencing report, it's not going to say there's a HER2 mutation. It's going to say ERBB2. HER2 is formally the name of the protein, whereas ERBB2 is the name of the gene. And this can be a little bit confusing unless you're used to seeing it a lot. So why do we care about HER2? Well, until recently, it really has been considered a marker of poor prognosis.
So I just realized that our online viewers cannot see your
Oh, goodness. Okay.
There we go. Okay.
All right. They've just had to look at me. So, interestingly, this is how breast cancer started off too. And as we developed treatments targeted at HER2, this became no longer a poor prognostic marker. And I think we're going to see the same in lung cancer. We also care about HER2 alterations because they can be mechanisms of acquired resistance to EGFR TKIs like osimertinib in patients with lung cancer. We know that these folks are unfortunately very likely to experience brain metastases similar to patients with other driver mutations. In fact, it's actually more common than in patients with EGFR mutant disease, which is already very high risk for brain metastases. And I do see there's some stuff going on in the chat, so let me know. That's probably the people who said they couldn't see my slides. So let's just talk about the different kinds of HER2 alterations, if we can get this to move ahead. There we go. I just had to magically point it to the right place. So this is a small diagram, but I really want to emphasize that there are 3 different types of HER2 alterations. These are sort of overlapping Venn diagrams. There are absolutely patients who have just one of these, or 2, or even all 3, but they are different. So we can have a mutation in the ERBB2 gene. We can have amplification where there are increased copies of the ERBB2 gene. And we can also have protein overexpression, wherein you just have lots of protein on the outside of the cell. When we talk about HER2 breast cancer, we're usually talking about overexpression. You'll notice that I'm going to focus in a lot on mutation today. Patients who have mutation may have overexpression. Patients who have amplification often, but don't always have overexpression. So it's important to remember that these are different and yet somewhat overlapping. So when we think about how to do this testing, specifically when we think about mutations, we're going to be talking about next generation sequencing using PCR. Most of the time, when you're looking for HER2 amplification, you're also going to be using next generation sequencing. You can use FISH, but that's typically not common practice. So when you send off your external sequencing, or should you have an internal panel, this is really where you're going to find out the results of amplification and mutation. Some of your reports are going to come back for amplification with a copy number. Some are not, and you actually have to contact the external vendor to find out the copy number. When we think about immunohistochemistry, that's typically going to be done as an internal test by your pathologist. Only uses 1 or 2 slides, and it is measured by extent of membranous expression from 0 to 3 plus. Similar to breast cancer, when we have a 2 plus or a 3 plus tumor, a 3 plus is considered HER2 positive, 2 plus is considered equivocal, and that's when we move to FISH to sort of break the tie and decide if this is a HER2 positive test or not. In that way, we're similar to breast cancer. In another way, deciding whether we're 0, 1, 2, or 3 plus, we actually tend to use the rules for gastric cancer as established by our pathology organizations. So let's talk about both tissue and liquid biopsy, both of which are critical and have some really key advantages and disadvantages. So what about tissue? Tissue is our gold standard. You can only do immunohistochemistry on tissue, and yet you have to have decent amount of tissue to do it. Sometimes cytology specimens are not sufficient. Of course, a biopsy is invasive, so thinking about rebiopsying somebody after progression may be challenging. You have a longer turnaround time, it may be several weeks, and tumors are heterogeneous. You may find that one area of the tumor has a different expression of HER2 than another. Of course, we can also do PD-L1 assessment on tissue as well. What about liquid biopsy? Well, this is great because we typically get it back in about a week. It's certainly very concordant, so it's specific. If you get a result on liquid, it's real. You're going to find it on tissue as well. However, it is less sensitive. So it is very possible to miss alterations using liquid biopsy. In addition, you're only doing DNA sequencing. So especially when you're thinking about some of these gene fusions in lung cancer, you will miss those sometimes with liquid biopsy. So there are actually some very nice studies showing that doing both of them at the same time can actually improve patient outcomes. So how do we look at an NGS report? This is sort of a typical report. And again, I think the things I really want to, again, be a broken record and drive your attention to are that it will say that there is an ERBB2 mutation. And you'll notice that they'll say there are some therapies with clinical relevance, some that are not good to use. They usually put them in red with a big X mark right next to it. And here you can also see the VAF, or variant allele fraction, how much of the mutation is found in the specimen. The thing is with liquid biopsies, as you all know, you'll find that the VAFs are very, very small. That doesn't necessarily mean they're not relevant. It's just that the tumor, the amount of ctDNA that is circulating in the body is typically quite low. So what about HER2 gene mutations, or technically ERVB2, but we'll just call them HER2 for today. Again, they're thought to happen about 2 to 4% of patients with non-small cell lung cancer. We tend to find them in women, in people who have never smoked, and in people with adenocarcinoma. I have plenty of people who are men who have smoked and who have mixed histology, just as a reminder that everybody should be screened. Typically, these are mutually exclusive of other driver mutations like EGFR, ALK, and KRAS. And 90% of these mutations happen in exon 20, which, as you can see below, is actually part of the tyrosine kinase domain where everything happens. Certainly, you can see alterations that happen in other places, for example, the transmembrane domain or even extracellular. And it's actually important to try to take a look, and this is where things like open evidence can be very helpful, to determine where in the gene this mutation is, to find out how likely it is that HER2 targeted therapy is going to benefit your patient depending on the treatment. So I keep referencing breast cancer a little bit because that's where development of HER2 targeted therapies began. And we know that HER2 amplification is much less common in lung cancer than it is in breast cancer, but HER2 mutations are much more common in lung cancer than breast cancer. And whereas, typically treatments like trastuzumab deruxtecan, which we'll be talking about quite a bit today, actually benefit patients with all levels of HER2 overexpression, including what we call ultra low in breast cancer, 0 with just a little bit of expression. In lung cancer, really, we have learned that high expression is required to get benefit. And as I mentioned, we use a different, really a different scoring system based on gastric cancer rather than the breast cancer scoring system. And your pathologists all know this, but it's just important to keep in mind that these are not identical situations. The NCCN recommends that HER2 mutations should be looked for as part of all broad molecular profiling. I think HER2 overexpression is another interesting area because, as I mentioned, you need tissue for this. So they've sort of waffled here and said that testing by IHC is recommended at some point during progression. We know that HER2 overexpression is dynamic. It can change over time, especially after HER2 targeted therapies. So, in an ideal world, when you're deciding whether or not to use a HER2 targeted therapy for HER2 overexpressed lung cancer, the more recent the specimen, the better. Not surprisingly, the European Society for Medical Oncology is a bit stingier because they tend to really incorporate financial considerations into their recommendations, and they focus here on doing NGS only for patients with non-squamous lung cancer. So, HER2 mutant non-small cell lung cancer, unfortunately, is not terribly responsive to immunotherapy. And we'll talk a little bit about how that may or may not affect your practice in caring for these patients. But you can see this is a nice study, one of many looking at patients with various driver mutations. And you can see that one could, simply conclude that these immunotherapies are not very effective for non-KRAS driver mutations, but in fact, it's actually a lot more complicated. So we know that we really ought not to be using these medicines for patients with EGFR, ALK, and ROS1 alterations. MET has been sort of in this gray zone. There have been numerous retrospective studies suggesting that maybe we ought to use it. It's not crazy to use it. BRAF seems to be a very immunoresponsive type of lung cancer, similar to BRAF mutated melanoma. And then we have HER2, which is not so great. So we'll talk a little bit about how that may affect your practice. So now, everybody, wake up. How do you guys approach biomarker testing and HER2 testing specifically in your practices? I'm interested to hear. And I will tell you a little bit about how we do it as well. Please.
So I order liquid reflexes every one.
I do the same. One of the nice things is that a lot of these external vendors are frankly willing to eat the cost if there's an insurance issue. What about anybody else on NGS? What is your practice?
Thank you.
Basically, all new diagnoses. I love it. And how about HER2 overexpression in lung cancer? Bit of a trickier situation. So you do it as an internal test? Um, and Caris does IHC as well for HER2. Fantastic. Fantastic. Not all of the external vendors do. Hmm. How often, just as a follow-up, sorry to put you on the spot, how often do you have sufficient tissue to do that as well? You've brought up such a key issue. I find myself struggling with the same and don't always have sufficient tissue to test. When I do, I certainly want to, but I think we're all sort of trying to figure out when do we do this testing? Certainly, if we have the baseline tissue, what about for patients where we're dealing with fewer options? Should we maybe try to rebiopsy at that time? But that's really an area still very much in development. But very glad to hear that some of our external vendors are doing this. So let's actually get to some ADCs. So here is a clinical case from my colleague, Dr. Sabari at NYU. This was a 47-year-old woman who had never smoked cigarettes, and she had 3 months of cough and shortness of breath. As you can see here on this coronal cut of her CT, she had a large right upper lobe mass, and there was also some mediastinal adenopathy. On PET scan, she also had some FDG avid hepatic metastases. MRI brain was negative for metastases, thank goodness, and she was feeling very well. Her performance status was 0. So she underwent an image-guided liver biopsy showing poorly differentiated adenocarcinoma favoring non-small cell. It was TTF1 positive, as we might expect, although as a reminder, 20% of lung adenocarcinomas are TTF1 negative. PD-L1 expression was negative, less than 1%, and thank goodness there was sufficient cellularity for NGS. And so this is her NGS report. And again, we see ERBB2. Now, this exon 20 insertion is something that we wrote in here. It's typically not going to be present on your NGS reports. YVMA is the most common ERBB2 alteration and occurs in exon 20. So this is in your tyrosine kinase domain. So it's important to keep that in mind because, again, not all HER2 mutations are created equal. Interestingly, I'll also note that this patient has a BRCA2 mutation with a very high variant allele frequency, suggesting this may be germline. So, first question, what treatment might you recommend in the frontline setting? And you don't even have to raise your hand, you could just say the letter. C. Anybody else? So it may be a little bit more complicated. C is certainly not wrong. I've slightly tweaked this to say chemo plus or minus immunotherapy first. Then we actually have now 2 FDA-approved options, which can be used in the second or later line, both zongertinib and trastuzumab deruxtecan, which I'm hereafter going to refer to as TDXD. We don't actually have a specified order of using those medications, and that's something we can talk about. So, how do you guys decide what to use when you're treating patients with newly diagnosed HER2 HER2 altered non-small cell lung cancer? What is your standard first line approach? I know this may sound straightforward, but typically when I ask my colleagues, the answers are not uniform. Who uses chemoimmunotherapy? Okay. How about chemo on its own? How about one of our HER2 targeted therapies? I do have colleagues at some centers who are starting to use those in the first line, although we don't have an FDA approval for that at this time. A very busy slide of our NCCN recommendations, as all of our NCCN recommendations appear, but let me just break this down. Basically, we have 3 treatments for HER2-driven disease, and specifically HER2-mutated lung cancer. We have TDXD, we have TDM1 or trastuzumab emtansine, which we'll talk about, and was developed before TDXD, and we have zongertinib, a relatively new player on the market, a HER2 tyrosine kinase inhibitor. The key thing to notice about this very busy slide is that none of these are recommended in the first line. These are all later line options. So let's talk about ADCs, and I'm actually going to try to complicate the discourse around ADCs just a little bit. So first, as you know, ADCs have the same basic structure. There's an antibody that's looking for something that's characteristic of the cancer and hopefully not characteristic of normal cells. a linker, which may be cleavable or non-cleavable, a payload, which is typically a type of chemotherapy that may be a little too potent to give on its own. And so the traditional explanation is that these are homing missiles that bring the chemo right to the cancer, which is a lovely explanation. It turns out that that's not completely accurate. It may be one of the explanations, but it actually turns out that when we do pharmacodynamic analyses, very little of the payload is actually brought and internalized into the tumor. So many other mechanisms are at work. So there may be a bystander effect where the payload is actually incorporated into the cell and then again recycled into the tumor microenvironment. There may be direct cytotoxicity via a payload release. And I think one of the key effects is actually a pharmacokinetic effect, where there's sort of a prolonged continuous release of the payload in the tumor microenvironment, creating prolonged cytotoxic levels. So this may really be an issue of timing. We also are starting to learn that there may be non-internalizing payload release. There was a recent lovely Nature paper showing that a specific enzyme, cathepsin L, is critical to this in breast cancer, and I suspect we'll find similar results in lung cancer. So the summary being, it's a little more complicated than the targeted missile approach. So what about our first ADC? This is actually the first FDA-approved ADC for a solid tumor, adotrastuzumab emtansine. DAR, or drug to antibody ratio, is 3.5. We typically think the higher the DAR, the better, although not necessarily, as again, we are really learning. I think it's important to keep in mind how much we don't know. And so this was really first approved in breast cancer. And there was a small phase 2 study in patients with HER2 mutant or amplified non-small cell lung cancer. You can see that there was a real response rate. The median PFS was on the shorter side of 5 months. Interestingly, HER2 expression was totally unrelated to response. This is not FDA approved, but it is part of our NCCN guidelines as an appropriate agent. And one thing to keep in mind about TDM1, just going back to the previous slide for a second, is that the payload here is a microtubule inhibitory compound. So you're going to get things like neuropathy. And it's also important to keep in mind what the payload is of the antibody drug conjugate you're using, as emerging data, especially from breast cancer, suggests that maybe using 2 ADCs in a row with the same payload may not be super effective. So let's move on to TDXD. Here, this is a HER2 targeted antibody, just like TDM1, and is attached using a cleavable linker to a topoisomerase 1 inhibitor payload, or DXD, deruxtecan. And this is a beautiful image of endocytosis of the agent and breakdown of the agent into antibody and payload. But as we talked about, there are many other mechanisms at play here. Let's go through the studies of this agent for lung cancer. They're a little bit complicated because some of them bring together mutation and overexpression, so I'll do my best to be very clear about these. So in the Destiny Lung 01 study, this was an exploratory study, so they had many populations. They had a cohort for HER2 overexpressing cancer, which could be 2 plus or 3 plus, and they had a different cohort for HER2 mutated cancer. And based on results, they plan to potentially expand these. So let's first look at the overexpressed cancers. So there were 90 patients. At initial report, only about half as many, but they continued to enroll here. And they actually looked at 2 doses. The dosing of this drug is going to be really important because we're going to talk about dose and toxicity in a few minutes. And you can see here that the response rate was there, but it wasn't terrific. It was around 30%. One thing I want you to notice in this waterfall plot is that actually most of these patients had IHC 2 plus disease. Why is that? Well, we think that IHC 3 plus disease is pretty rare. The literature is all over the place, but the latest data suggests that it's really in the single-digit percentage. So it's hard to know what the real response rate is because, again, this was mostly IHC 2 plus patients. And so very modest activity in those. Of 9 patients with IHC 3 plus, 44% responded. That's very small numbers. But we are learning more about these overexpressed patients, and we'll talk a little more about that. As you can see here, patients had many other mutations, as you can tell, which really did not seem to impact response. When you look at the purple line with HER2 amplification, this really did not seem to correlate with response at all, which is pretty interesting. And a good reminder that amplification and overexpression are not the same thing. What about the HER2 mutated cohort? This was very promising. So here, everybody got the higher dose, 6.4 mg per kg. There were 91 patients. These patients may or may not have had expression that was increased or amplification. You can see mutation on the top, looking at the exon. So really, most of these patients in the blue had TKI, tyrosine kinase domain, TKD mutations. Some of these patients had high HER2 expression, did not necessarily relate to response. And a few of these patients had HER2 amplification. Some of them had had previous HER2 targeted therapy. When it says HER2 TKI therapy, these were non-specific TKIs that target multiple targets, often across the HER1, HER2, HER3 family. So not more non-specific toxic agents. And here we saw a response rate of 55%, a median duration of response of duration of response of 9.3 months, and a median overall survival of 17.8 months. And these, I think, results were pretty exciting to all of us. And so let's really focus in for a moment on what the adverse events were. So nausea was really common. And I'm sure we'll talk a little bit about those of you who have experience with this drug and what you've observed. 64% of patients had nausea and 9% had grade 3 nausea. Fatigue was also common. You can see that cytopenias were quite common. And in fact, 15% of patients had grade 3 neutropenia. So this is chemotherapy. I have had one colleague say to me, well, it's just sexy chemo, which is an interesting way of looking at it, but it's a reminder that we are still giving chemotherapy when we're giving these ADCs. So let's talk about one of the key AEs, which is drug-related ILD or pneumonitis. Both terms are used. When they looked at this cohort, 26% of patients had ILD or pneumonitis, and in fact, 2 patients died from this pneumonitis. Median time to onset was 141 days. One thing to point out was that most were grade 1 or grade 2. As a reminder, grade 1 means that patients are asymptomatic. Grade 2 means that patients are starting to become symptomatic, and it really can be quite disabling. So there's quite a large difference between grade 1 and grade 2. Most of these patients got steroids, and at that time, patients were not necessarily receiving steroids according to universal guidelines, but most of them were. So after this study, the question really was, this drug clearly has efficacy in HER2 mutated lung cancer, but what about the toxicity? Can we still get that efficacy without hurting patients? And so the DESTINY-Lung02 study again looked at patients with HER2 mutated lung cancer who had previously received standard platinum-based therapy with or without immunotherapy. It was a 2-to-1 randomization. 2/3 of the patients got a lower dose, 5.4 mg per kg, which, by the way, is the dose approved in breast cancer. And 1/3 of the patients got 6.4 mg per kg. So let's really focus in first on the efficacy data. This is a very busy slide, so our handy rectangles will help us here. Comparing the two groups, efficacy was quite similar. So in the lower dose group, 5.4 mg per kg, the ORR was 50%. It was a little bit higher, 56% in our smaller cohort of the 6.4 mg per kg. So pretty similar efficacy. When we look at pneumonitis, this is where we see a huge difference. 15% of patients on the lower dose developed pneumonitis, whereas 32% on the higher dose did. And even when we look down at the bottom at all safety events, you can see that 60% of patients on high dose had a grade 3 or higher event. That's really quite high compared to about 40% in the lower dose group. And certainly more patients on the higher dose had AEs that were associated with drug interruption, dose reduction, or dose discontinuation. I think that's really, really clinically relevant, right? We want our patients to be able to get medicine, continue medicine, and benefit from it. If you can't take it, you're certainly not going to be able to benefit from it. What about intracranial effect? A busy slide to show you that they essentially took all of the patients from both of these studies and looked at response with brain metastases. They were specifically looking at patients with both actually HER2 mutated and HER2 overexpressed disease. And they included patients who both had asymptomatic, untreated brain mets and patients who had already received treatment. So I want to just point out here that in these waterfall plots, which are very nice, we like to see most of the bars go below the 0%, showing that they shrank. The dark blue shows patients who have not received prior treatment for brain metastases, whereas the light blue shows patients who had received prior treatment. And so I think it's actually very, very important to point out that we have responses in patients with untreated brain metastases. I think it's hard to summarize the response rate intracranially when we combine patients with treated and untreated brain metastases, especially when you've done radiation. And we know that the effects of radiation can develop over many, many months after radiation. But important here that there is a nice response rate in patients with untreated brain metastases, especially as we know that brain mets are very common in this population. Right now, the Destiny Lung 04 study has completed accrual. It's looking at standard of care chemoimmunotherapy versus TDXD in the first line, and we await the results. So the Destiny Pan-Tumor-O study is actually important even though it didn't include lung cancer. I led this study at Sinai, and basically we found that trastuzumab deruxtecan was very effective across numerous tumor types that were IHC 3+. So going back to overexpression from mutation. Unfortunately, it was not effective in pancreas cancer. Really hard to determine why, but this actually led to a pan-tumor FDA approval of Enhertu or trastuzumab deruxtecan for patients with IHC 3+ tumors. And so just take a minute, and I'm interested in your experience with TDXD. Certainly happy to share my experience, which has been very variable by patient. Tell me about how your patients have tolerated this agent. Have folks in here actually had an opportunity to use this agent? How has it gone? Really fairly well. Great. I have treated a lot of patients because of this trial and because of my lung patients. It's very variable. I can say that I've definitely seen patients who are really minimally affected. I've also seen patients develop severe pneumonitis. I would say that nausea is a feature that I have noticed quite often. So we'll talk about AEs and their management in a few minutes. So going back to our case, this patient received first-line carboplatin and pemetrexed. And I promised that we would talk about this for a moment. Do you use immunotherapy in the first line? So I think we had one person raise their hand, one brave person say that they do. Does anybody else use immunotherapy in the first line or make another choice? Don't be shy. So, well, what I will say is that I think opinions on this are evolving. I used to, and I actually don't anymore. But I have many colleagues, other thoracic oncologists across the country, who feel very strongly that their patients should receive immunotherapy. We do have data from EGFR mutated lung cancer that giving TKIs after immunotherapy can be quite toxic. We actually don't have that same data in lung cancer. And so I would say this is an area, a gray area, and I think there really is no wrong choice here. So this patient responded to initial therapy and then after 7 months had progressive disease. So what can we do next? Can I have some letters shouted out? There was one brave person last time. I think we can get at least two.
Because I did see the response rates on that before, and I had forgotten about that when I mentioned it, and that's a great question.
So you would choose zongertinib. Great. Anyone else? So, trick question. We actually have several appropriate medications. We could use trastuzumab deruxtecan. We could use zongertinib. Clinical trial, as a clinical trialist, I have to point out it is always a grade 1A recommendation from the NCCN. We actually, certainly per NCCN, can use TDM1, the other ADC we spoke about. Most people have stopped using that given the higher response rates seen with TDXD, but it's important to remember that it remains in our NCCN guidelines. So this is this patient who received TDXD. You can see that their primary mass responded pretty significantly after 6 months. I want to point out that there are many similar medications that are in development. 3 of these agents are also antibodies connected to a topo-1 payload. One of them, which we have at Sinai, is interestingly a HER2 STING bispecific, essentially trying to activate immune cells to get to the cancer. So not quite the regular type of payload that we think about. What about tyrosine kinase inhibitors? And now it is time for me to take a drink of this. One moment. So on this slide, there are numerous drugs, all of the drugs at the top that are not part of this rectangle, essentially target multiple tyrosine kinases, usually in the HER2 family. So HER1 is EGFR, HER2, HER3. These are nonspecific drugs. You can see that they don't have great response rates. And then over the last 10 years, there have been development of more targeted drugs. Most of these drugs have been pretty hard to tolerate. I don't know if anyone in our audience has experience, for example, with poziotinib. This was a drug that caused very, very significant rash. And ultimately, despite having a meaningful response rate, development was discontinued. You can also see that diarrhea happened in 92% of patients and was quite severe in some cases. The same was true for pyrotinib, another HER2 targeted therapy. So let's talk about zongertinib, which I mentioned was recently FDA approved in the later lines after first line treatment for patients with HER2 mutated non-small cell lung cancer. So this study, like many others, has many arms, and so I've tried to use color coding to illustrate how patients did on each of these arms. So we've not had all of the arms reported yet. Cohort 1 consisted of patients who had received chemotherapy and or immunotherapy before, who specifically had a mutation in the tyrosine kinase domain. This was important because of the way the drug worked, essentially blocking HER2 at the tyrosine kinase domain. Here, the response rate was the highest. It was 71%. For patients with similar mutations who had previously received an antibody drug conjugate, in most cases TDXD, the response rate was a bit lower at 48%. And I want to give them credit because they also looked at this drug among patients with non-TKD mutations or patients who actually had TKD mutations and squamous lung cancer. Here, there was still a meaningful response rate, but it was quite low. Next, I'm going to show you the results that were just presented at ESMO looking at first-line patients who had received no treatment before, who had TKD mutations. Here, as expected, right? The earlier we move treatments in our treatment course, usually the higher the response rate. This had a response rate of 77%. A lot of these responses were quite deep. The median duration of response here was 9.7 months, as you may or may not remember, similar to what we've seen with TDXD in the later lines. So what about this drug? How does it make people feel? So like any tyrosine kinase inhibitor, I'm always telling our fellows, if someone asks you what the side effects are of a TKI, you can always say rash and diarrhea. But I think the key is how severe were these rashes and were diarrhea. So first of all, actually, rash is not super common with this agent. 54% of patients had diarrhea. Low-grade diarrhea, typically, grade 3 was seen in only 3% of patients. Increased LFTs transaminases were seen in a not insignificant number of patients. Patients do develop nausea, and some ILD pneumonitis was seen, although no relationship between prior immunotherapy and development of pneumonitis was observed. And this drug also appears to have some intracranial efficacy. This data was presented at World Lung just a couple of months ago, and again consists of patients. Actually, all of these patients here, unlike the TDXD data, had not received radiotherapy to their brain metastases. Some of the patients had received prior systemic therapy in the dark blue, and others had not. And here they saw an intracranial response rate of 44%. So these agents do have activity in the brain. And then, although this has not yet been approved, this is another TKI that is specific to HER2, cevabertinib, and these results were just presented as well, and I think it's important to be aware of them. Cevabertinib, similar to zongertinib, is an oral reversible TKI that specifically inhibits mutant HER2. It does inhibit EGFR, but it has high selectivity versus wild type EGFR. It hits EGFR a bit more than zongertinib does. And in this phase 1/2 study, SOHO-1, they looked at patients with HER2 mutations. These folks really focused in on the tyrosine kinase domain mutated patients. And so again, just like the other study, lots of arms with different response rates. Cohort D looked at patients who had had prior chemo and immunotherapy, but who had not gotten HER2 targeted therapy. And the response rate there was 64%. It was even higher in patients with treatment naive disease, 71%. And just like our other agents, was lower in patients who had previously received a HER2 targeted ADC, 38% here. We similarly see these median durations of response in the not quite 1 year, maybe 3/4 of a year period of time. And this study showed grade 3 or higher treatment-related adverse events in 31% of patients. The most common TRAEs were diarrhea. We see that it was actually quite common. Rash happened quite a bit more here than with the other TKI. We see hypokalemia, which actually was seen in grade 3 for 6% of patients, and nausea and vomiting. There were no cases of ILD or pneumonitis reported. And so that agent is not yet approved, but quite far along in development, important to be aware of. So let's take a moment and talk about some key adverse events. So nausea. As I mentioned, this is a trastuzumab deruxtecan, which we have the most experience with clinically, has a very high emetic risk. And then we'll focus also on interstitial lung disease and pneumonitis because although this is rare, it can be life-threatening. I briefly also want to mention that a lot of our ADCs have similar, not fully overlapping toxicities, but somewhat. So many of them can cause pneumonitis. Some of them can cause severe stomatitis, typically not the HER2 targeted therapies that I've mentioned. Some can cause ocular toxicities, and these are all usually related to the antibody. And then we have GI effects, which are largely due to the effects of the chemotherapy. So let's talk for a moment about ILD. We know that there is a higher risk of pulmonary adverse events in patients who have pre-existing lung disease. You may say, well, what about my population? Many of them have COPD. It's really important to think about how their pre-existing lung function is, what does their scan look like, and to be really extra aware in those patients that they may be at higher risk of ILD with TDXD. So how does this look? Patients often develop a cough, they may become short of breath, you may notice wheezing. Sometimes people can get a fever, although I don't see it that often. And radiographic changes usually show pretty diffuse bilateral ground glass opacities. Whatever grade it is, the first thing you do is stop the TDXD. Even if you're in the middle of infusion and you see a CT, stop the TDXD. Make sure you have a high resolution CT to confirm it. You don't necessarily need contrast because again, you're focusing on the parenchyma. Ideally, involving a pulmonologist is really helpful. Sometimes it's hard to get somebody into pulmonology really quickly, but if you have somebody that you collaborate with frequently, this can be really beneficial. Sometimes you want to rule out infectious disease as well. So what about grade 1 pneumonitis? And again, this is pneumonitis that is just seen on the scan. Typically, we stop the ADC, we monitor symptoms really closely. I like to see these people within a week, and then typically about 1 to 2 weeks later, I'll get a repeat CT chest. Steroids can be used in this setting, but they don't have to be used. And if a patient's grade 1 pneumonitis, if their CT changes don't fully resolve, I really hesitate to restart this drug. What about when the pneumonitis becomes symptomatic? Don't wait. Start steroids. You may want to make sure you're ruling other things out. You may be referring somebody to a pulmonologist. Don't hesitate to start steroids until that evaluation takes place. Typically recommend prednisone 1 mg per kg a day or the equivalent. And this tends to be something that needs to occur over a large number of weeks. It says here over 4 or more weeks. Typically, I continue the 1 mg per kg until a patient is improving clinically and then begin a gradual taper, typically 10 milligrams per week, but really in consultation with my pulmonary colleagues. If the patient's not getting better quickly, consider upping the steroid dose or even thinking about alternate therapies. We have many other immunosuppressives that are sort of loosely recommended in our ASCO and NCCN recommendations, such as IL-6 inhibitors, infliximab, and so on. But again, use those in consultation with your pulmonologist. And I would not restart an ADC for a patient who had grade 2 pneumonitis. Grade 3 or 4, this is very serious, typically requiring hospitalization, even life-threatening. And here I typically start IV methylprednisolone. And again, keep going. Don't start dose reducing until your patient is feeling much better, and never give them more ADC, please. As I keep gesturing to, the multidisciplinary team is really critical here, especially pulmonology. If you have odd rashes, right, having a dermatologist who has experience with these agents can be incredibly helpful when you're thinking about other issues such as really treatment-resistant nausea. Having a palliative care consultant can be helpful if your usual tricks are not making a difference. So, any challenges or AEs, toxicities that have been particularly notable for you? I know you said that your patients have been tolerating this pretty well, which is fantastic. Any other toxicities that folks have noticed in their practice? I certainly don't assume that mine is representative. Anybody noticing nausea? If I could just have a few hands. Okay. How do you typically treat the nausea?
Nothing really unique that I've.
Nothing unique. You know, one thing I'll say, and then this is really a very similar question in terms of how patients tolerate it. I have found myself really going more and more toward the low dose olanzapine, 2.5 milligrams QHS, for really excellent control of nausea. Just have to make sure patients take it at night or they'll be sleepy all day. But really for resistant nausea that is not that is present all day despite the use of our ondansetron or other medications, I find it very helpful. And it's now actually an NCCN grade 1 recommendation. And so toxicities that are most difficult to manage. Has anybody dealt with pneumonitis in the room? Thank you, brave person. Um, how has that been for you?
Just one case. Yeah.
Yeah.
And it was a breast cancer patient.
Yeah.
Widespread lung metastases, which was kind of a bad setup for it. And she also felt strongly about staying on the medicine because it was also ambiguous. She had, kind of scans that couldn't really tell if there was lymphogenic spread or
Always so hard to tell. Yeah.
so for her, it's a challenge, and she got steroids and ended up getting infliximab and still passed away.
Yeah. I have had I have had patients pass away as well from pneumonitis or find it permanently disabling. And although it's rare, it's a risk that I really very openly share with folks. The earlier you recognize this, the better. The earlier you start steroids, the better. But there are a small number of patients who really have very treatment refractory ILD. So, what about educating patients and caregivers? This is critical. I already gestured to this. So, really talking to patients about letting me know if you are coughing more, if you are more short of breath, if you are having worsening diarrhea. Sometimes I tell my patients they really hesitate to call me. And so I've even resorted to saying that I'm lonely if they don't call me. So, please call me. Really stressing that the earlier we recognize adverse events, the better. I think a lot of patients worry that they're bothering you. I've also had a lot of patients say, well, I was going to see you in a couple of weeks, so I just figured I'd tell you then. Or, I figured this was one of the side effects you told me about, so I just have to deal with it. So I've really tried to change the education that I give by saying, just because it's something we talked about doesn't mean I can't help you feel better. So call me, let me know what's going on. So, just in conclusion, as we reviewed a lot of information today, HER2 alterations in non-small cell lung cancer include mutations, amplifications, and overexpression, with mutations really being more common, although still rare in non-small cell lung cancer. And we know that we need next generation sequencing to test for ERBB2 mutations in patients with advanced non-small cell lung cancer of really any histology. We know that antibody drug conjugates like TDXD and tyrosine kinase inhibitors like zongertinib and cevabertinib have shown clinical activity in this disease. And now we want to do our best because we know that HER2 IHC is recommended for patients with all solid tumors. That remains a sort of moving target as we try to work with our colleagues to gain more substantive tissue samples to make sure we can do that. But because of the Destiny Pan Tumor 02 study, TDXD is FDA approved for 3+ tumors, regardless of histology. And then lastly, the critical nature of multidisciplinary collaboration to monitor, identify, and really treat early adverse events that are associated with this therapy. So thanks so much, and I'm happy to take questions. An extra thank you to the gentleman who offered their experiences.
Do we have any questions from the audience? All right.
Yes.
I don't have any recent clinical experience, but I'm curious about the difference between HER2 overexpression and HER2 mutation and how it relates to cellular proliferation. My understanding from, our breast cancer patients back in the day was when you had HER2 overexpression, it contributed to cellular proliferation and also sort of the characteristic of metastases and how the breast cancer progressed. How do the mutations relate to cellular proliferation, the characteristic of cancer? That's one question. The other question is,
do you mind
you
if I
haven't
answer
mentioned
that first? I'm not great at remembering multiple questions.
Oh, okay.
Thank you so much. So, typically, these mutations are in the tyrosine kinase domain, so they keep ERBB2 in a permanent on position so that there is basically continuous downstream signaling, whereas overexpression just means there are more molecules on the outside of the cell, more proteins to dimerize and have that downstream expression. So it's perhaps even, in a way, more overactive.
So they both contribute to progressing cellular proliferation, but the mutation actually is more integral. Is it tyrosine kinase also?
It is.
Okay. So I noticed that some of the drugs now are both HER2 inhibitors and tyrosine kinase inhibitors. Are those, just out of curiosity, like the Zonagrib, is that being used in breast cancer?
So there are.
Could it be used in breast cancer?
So there are studies ongoing in breast cancer. There's a large study we're participating in looking at zongertinib in patients with over 20 different tumor types, both HER2 overexpressed and mutated. I think one of the interesting things about this field that I think you're gesturing toward is that we're using the same medications to target totally different molecular pathways, including overactive tyrosine kinases and then overexpression of proteins that need to homodimerize to activate. And interestingly, we do see this activity across tumors. As I showed you with TDXD, it does seem like that there may be less activity in the HER2 overexpressed tumors. It's unclear how that's going to shake out with respect to zongertinib, because it is not an antibody, right? It is simply occupying the tyrosine kinase domain.
And could you comment on the lack of any evidence of cardiac toxicity, which is very common in breast cancer, or something we're always concerned about with the HER2 drugs?
Absolutely. So there is very minimal cardiac toxicity with TDXD, although it has been seen, and our guidelines recommend regular echoes at baseline and on treatment. So I do this for all of my folks on TDXD. With zongertinib so far and cevabertinib, we have not really seen that signal. Remember that, of course, as you know, all of this comes from our original trastuzumab data, which is, of course, the antibody that is involved in all of these ADCs. So it remains to be seen, really, whether these TKIs will result in a similar cardiotoxic profile, although so far it doesn't seem that they do. And TDXD, while having some cardiotoxicity, does not seem to be anywhere near the risk of these drugs in breast cancer.
I wonder why that is.
As do I. And
Yeah.
I will be the first to acknowledge that, these are not, that histology does matter.
Back in the day, it always seemed like if you had a gene mutated cancer, that it was mutually exclusive to the immune checkpoint inhibitors. Is that still the case, or do we see immune checkpoint inhibitors being used in gene mutated driven cancers?
Great question. Totally depends on the mutation. So I can say that I don't have any colleagues who would use immune checkpoint inhibition in patients with EGFR, ALK, or ROS altered cancers. I would say that BRAF, we have substantive evidence that it is very effective. And this is similar to melanoma, where we know that actually BRAF V600E mutations, which are the BRAF mutations I'm referring to, actually, these patients are just as responsive to immune checkpoint inhibitors as patients without these mutations. And we're seeing the same in lung cancer, although it's hard to evaluate because it's much rarer. But we have really, I currently have a patient with a V600E mutation who was on targeted therapy for many years, had disease progression, and is now having a CR to ipilimumab and nivolumab. MET, as I mentioned, is a moving target. I allow myself, I think, hopefully healthfully, to talk to colleagues and think and rethink my practices all the time. I have started to use it again after a period. There was a retrospective review that showed an awful response rate, and I sort of moved away from it. I have been moving toward it and seeing some efficacy there. RET, there is some response rate, probably in the 20s. It's not something that I would use until after I had exhausted targeted therapies. KRAS, of course, we know those patients have a wonderful response to immunotherapy, but that's sort of apart from this general other area of driver mutations we're discussing. So I think it's really important to remember that the mutation matters quite a bit. And then HER2, as I mentioned, I do not use immunotherapy personally. Go ahead, Sarah.
Thanks.
Sure.
Do we have any other questions? All right, I'll
All
check
right.
our Zoom just in case we have any online questions. And seeing none, thank you so much, Dr.
My pleasure.
Show.
My bag is behind you. It is okay.
We'll go into a 15-minute break. So make sure to grab some snacks and talk to our exhibitors next door. All right. Well, good morning, everyone, and welcome back. As we're waiting for people to trickle in from the next door. Um, but for our next segment, we'll have Dr. Laura Alder with a presentation on the current management of small cell lung cancer. Dr. Alder is a thoracic medical oncologist and assistant professor of medicine at the Duke Cancer Institute, where she specializes in lung cancer and central nervous system metastases. Her work focuses on biomarker-driven therapies, novel treatment strategies for molecularly defined lung cancers, and improving outcomes for women and minorities affected by thoracic malignancies. Dr. Aller serves as principal investigator for several early phase clinical trials and has published extensively on lung cancer genomics, brain metastases, and circulating tumor DNA. Nationally, she is an active member of IASLC, NRG Oncology, Atomic, and other leading research groups. She also serves as Deputy Director of the Duke Center for Brain and Spine Metastases, and is recognized for her leadership and dedication to advancing lung cancer care. Welcome, Dr. Alder.
Hi, thank you so much for that introduction and for having me here. I'm sorry I can't be with you all today. I'm going to start sharing my slides. Can you see them? Okay.
Yes, hold on. Let me make sure that our folks here can see them.
Okay, perfect.
Um, there we go.
Okay, great. So again, thank you so much for having me. I'll be talking about the current management of small cell lung cancer. And these are my disclosures. And really, one of the themes of the conversation is hope. It's Lung Cancer Awareness Month here in November, and there's so many exciting things happening. So it's a great time to be in lung cancer and to be able to offer so many new options for our patients. So this is an overview of what I'll discuss today. I start with a case presentation, go into some of the new data in early stage, much more so in late stage, future strategies, and then would love to open it up and have some good discussions. So starting off, I think this will resonate with a lot of us. 54-year-old male comes to clinic, history of diabetes, CAD, a lot of history of smoking use, about 65 pack years for this gentleman. He actually got into a car accident, which led to pan scans. And on that scan, we saw a 7 centimeter left mass invading into the left hilum and mediastinum, as you can see here on the right. Also identified bilateral adrenal metastases. The patient was very, very, very claustrophobic, so we did a CT brain. MRI brain would have been preferred. Thankfully, that showed no evidence of disease. So standard frontline of treatment, carboplatin, etoposide, and durvalumab. After 2 cycles, we saw a really nice response. After 4 cycles, an ongoing response. So continued on durvalumab maintenance treatment. However, after 8 months, he did develop brain metastases, the largest of which you can see here on the right. He completed SRS and continued on durvalumab. Unfortunately, 4 months after this, CT scan showed more widespread metastases. So the decision was made for second-line treatment to start tarlatamab. He's had an incredible response to tarlatamab, very thankfully. There's no evidence of disease on scans, including every 3 month brain imaging as well as body imaging. So that is terrific, but it's come at somewhat of a cost. He has significant taste changes and appetite loss, leading to significant weight loss, 46 pounds. As you can imagine, it does affect quality of life. So it's always a trade-off. But he still is on tarlatamab and working with nutrition and palliative care. So, which leads us into some of these new developments. For a long time, we had really little progress in small cell lung cancer. In the past few years, there's been so many new treatments. I think anyone who's followed the recent even ESMO World Lung, so many new treatments available, and these have trickled into changing how we treat lung cancer in clinic, small cell lung cancer. So starting with limited stage, here is a nice overview that was recently published in JAMA this year, showing surgery, radiation, chemoradiation, depending on stage 1, 2, 3. We don't really see a lot of the stage 1, early stage 2 that make it to surgery. See a lot more of the chemoradiation group. And this is some of the history of limited stage. And I like this slide because it kind of walks you through, look how far we've come, right? Even when we think about radiation treatments, and that's continuing to evolve with modern technology, new ways of targeting both the brain and the body. Chemo RT beats chemo, BID beats daily, and modern chemoradiation has extended even further that survival rate for our patients with limited stage disease. I think we're all familiar with the Adriatic trial. This really changed the course of after chemoradiation. Instead of doing nothing and surveillance, we add in durvalumab and continue that for up to 2 years. Don't usually make it to 2 years, but in some cases we can. But this has shown to really happily improve overall survival. We can see here at the 2 year mark and the 3 year mark, that improvement over doing nothing in the maintenance phase. We'll also see, not surprisingly, the progression-free survival and how that's improved the time that a patient can be on this. I think the nice thing is that with the durvalumab, it's pretty well tolerated. It's every 4 weeks. Still a bit of time toxicity, but overall, it's a nice mix between keeping the disease in control for longer and trying to get a durable response, and having the patient live a good quality of life. Because we know still, when we look especially at this PFS, about half of patients still do progress at about the 1.5 year point. And I think this also nicely shows, this will be a common theme, this durable responders in small cell to this immune type of treatment. And that's something I'll mention a few more times in the talk, but that's a really intriguing thing to keep in our minds as we go on. There were some interesting subgroup comparisons. I know this comes up a lot, carboplatin versus cisplatin, especially in early stage small cell lung cancer. We really want the best benefit for our patients. This was an interesting subgroup analysis, maybe suggesting that durvalumab worked a little bit better, it seems, with carboplatin. Again, it wasn't powered for this. This was kind of just an interesting observation. I usually prefer carboplatin for most of my patients in this group just because it is better tolerated, a little bit less toxic. I don't have to worry so much about kidney issues and autotoxicities. And then the other really interesting subgroup to come out of this study was the use of prophylactic cranial irradiation. I think it's kind of a hot topic. I think most of us in academic centers are not using prophylactic cranial irradiation. Sometimes it's a discussion, especially amongst younger patients, perhaps. But this showed us that durvalumab worked very well across both subgroups, those who did and did not get PCI. So that was an interesting observation that the use of PCI didn't seem like it improved durvalumab. I know there's always that question of does radiation have any synergy with immunotherapy? This suggests it works well with or without. Another study, there's a couple studies that are ongoing. This is one I'm part of the Alliance group, and this is through Alliance and SWOG. I thought this was a really interesting design looking at PCI versus no PCI, and really incorporating MRI brain surveillance, which again, I think all of us are doing in clinic, a brain MRI about every 3 months or so. And this study is directly comparing PCI versus just doing surveillance and kind of tackling the issues as they arise. versus putting a patient through PCI. And interestingly, their primary endpoint, this was changed throughout the trial design a bit, is now cognitive failure-free survival, which I thought was an interesting endpoint, but a very important one, because we know that brain radiation can really affect quality of life and has a lot of downstream effects. So moving on a bit into extensive stage small cell lung cancer, lots of different agents, especially towards the bottom there. You know, in the past we just had maybe one or two, and now we did thankfully have more and more, and that's really moving the survival point further and further. So we're going to start with frontline treatment, and I'm sure as everyone in the room knows, chemotherapy, platinum, usually carboplatin and etoposide, plus an immune checkpoint inhibitor, either durvalumab or atezolizumab. And so this was the study that looked at atezolizumab in the extensive stage setting, along with the chemotherapy backbone, all given together. And so this showed the progression-free survival benefit, as we can see here, for the median difference here was very significant. And survival, again, this was huge because before this was really the first trial that showed an overall survival benefit in such a long time for small cell lung cancer. So this was huge when it came out because we had been looking and waiting for a win. And so this was a very nice, clear survival benefit, both at 12 months, 18 months, and a little bit more recently, last year, we have the 5-year survival benefit. And as I discussed before, the theme of durable responses, it's amazing looking at this that 12% of patients, 60 months who receive the TEZO, smallish number, 200 patients, still alive at 5 years. So really interesting. I think as we learn more about kind of what biomarkers, what subtypes of small cell kind of fit into this category, we'll be able to kind of make sure our treatments are even better focused on the patient sitting in front of us. And similarly, we have the Caspian, and that looked at the addition of durvalumab to chemotherapy. We see here as well improvement in progression-free survival. Also see an improvement in overall survival. Both of these are now very standard of care as long as the patient doesn't have any contraindications, very similar to how we use immunotherapy in non-small cell lung cancer. And now we have another option. This just came out in ASCO of 2025. And so this looked at after the patient has finished all of the induction, so 4 cycles, this used atezolizumab as the immune checkpoint backbone. This randomized in the maintenance phase to either atezolizumab alone or the addition of lurbinectedin. So I want to point out a few things here in the trial design. It did not allow for any CNS metastases. And we know the CNS mets are very common in small cell lung cancer, upwards of 50% at diagnosis. No crossover was allowed in this study. When we get to the randomization point, only 73% actually made it to maintenance, to the randomization. This happened for a few different reasons, but one of the big reasons was disease progression and or just the patient no longer being in that ECOG performance status of 0 to 1. I think this just reminds us of how aggressive small cell lung cancer can be and how we really need to maximize the frontline therapy. And I'll get to this towards the very end of an exciting new trial with tarlatamab. And then another good point was the lurbinectedin arm received GCSF as prophylaxis. And so when we're looking at some of the toxicities associated with this trial, that's good to remember and think about as we incorporate this into practice for some of our patients. So the PFS was very real. You have to remember too, this is from the point of randomization. So we have to add in an additional 12 weeks to this data to include the induction phase. But we see a clear improvement in progression-free survival, not surprisingly for the patients who had additional maintenance therapy with lurbinectedin. Also, very importantly, the PFS benefit was coupled with a survival benefit. And so that's something that is always, I think a lot of us were waiting for to make sure that it didn't just improve the progression-free survival, but actually improve the survival for our patients. And so we see a nice survival benefit of about 3 months from that randomization point, which is always really important to consider. And then, of course, it's always a balance, right? We know that these endpoints are great. And when we talk to patients, we always quote this, but we also have to think about what are the downsides? What are the risks when we're giving additional treatment? And so we see here any treatment related AE rose from 83 versus 40%. Grade 3 to 4, 26 versus 6%. And again, this is in the maintenance setting. So we're adding lurbinectedin to durva, or to atezo, sorry, to atezo alone, which we know is well tolerated. Not surprisingly, a lot of these were heme related. Lurbinectedin is a chemotherapy, and everything we would expect there. And then serious AEs, 12 versus 4% with atezo alone. So I think, at the end of the day, it's a conversation with our patients. It's about who do we want to, is the juice worth the squeeze? Which of our patient populations would most benefit from this? When I'm seeing patients, I think about how well did they tolerate carboplatin and etoposide. I take into account like age, performance status. In this trial, everyone was ECOG 0 or 1. It's pretty different sometimes in the patient population we see in clinic with small cell lung cancer. And it's always a discussion with the patients about what they would like to do. But I think we also have to think about we have such good second line therapies that we want to make sure that they get to that point too. So lots to think about, lots to discuss. And so that leads us to extensive stage small cell lung cancer. I think the first point that we'll discuss is tarlatamab, which has rightly so gotten a lot of attention. It's kind of the new kid on the block, very exciting for small cell. It was approved in May 2024. Time flies. And it was based on Delphi 301, which is a phase 2 trial. And this was anyone in second line or above. It had a 40% ORR, objective response rate, 9.7-month median duration of response, really good median OS, 14.3, which moved the curve up from a traditional of about 12 months. Bispecific T cell engager grabs the DLL3 on the tumor cell, grabs the CD3 on the T cell, brings them together, activates the immune system, and results in cancer death. So this was recently presented at ASCO. This was the phase 3 trial looking at tarlatamab in second line treatment. Of note here, 44% had brain mets in the tarla arm. And so they were pre-treated, not active, asymptomatic, but treated or untreated brain mets, not active. But this was a really important point that a lot of the previous trials did not allow. So that was nice to see that. This was the data from ASCO looking at the phase 3 trial with tarlatamab. Median follow-up of 11 months. We saw that the survival benefit was significant, reaching almost 14 months here, which was even more of an improvement. And this pretty much cemented the use of tarlatamab in second line for those patients who have access to it, which we'll talk about a bit more later. This looks at the progression-free survival and some of the other endpoints, including objective response, median duration of response, ongoing response at data cutoff. Again, we can see here the point, we see that durability in a number of these patients. And going back to my case presentation at the beginning, some of these patients who do achieve a response, and we can see, I wish that response was even higher than it is. But we can see from that people who do achieve that response, they can have such a long duration of response on this treatment. One of the subgroup analyses, two of the ones that stuck out to me was the presence of brain mets, yes or no. We can see here that tarlatamab did significantly better than chemotherapy alone with the presence of brain mets, but a clear benefit across both groups. And then similarly, in the chemotherapy-free interval, one of the things we worry a lot in small cell is, are they platinum resistant or sensitive? And that can really impact what treatment we choose and how effective that treatment is. So this was a nice analysis that showed tarlatamab works really well and is better than chemotherapy, no matter platinum resistance or sensitive. So that was a nice thing that we saw from that. And then we have some CNS data, since they did include patients with brain tumors that could be measured. And so we see from the phase one, this was our initial one, this was with 10 milligrams and 100 milligrams, but we see a pretty nice change in the CNS tumor from baseline here. A lot of the patients are having a response. And then from the phase two trial, you can see here on the left, more than 30% decrease in CNS lesions, and more than half, again, small numbers, but still very encouraging since this is such a big problem in small cell lung cancer. And the disease control rate, which is not just a response, but stable disease, which we know is a huge win too, occurred in the vast majority of patients. And then on the right here, we've had a lot more real world data with tarlatamab recently. And this was a nice publication that looked at a handful of patients in the real world setting who did have active brain mets. And this illustrated some of their very nice responses to tarlatamab. This was, we at Duke, we collected some of our own data. We're about to have a follow-up with that. That's coming up soon, but MD Anderson and UVA also looked at those patients in the real world setting who did have CNS involvement. And we can see here a little bit less than some of the trials, kind of a wide range, which maybe is expected with real world settings. A lot of these real world settings saw anywhere from like 2 to 7 previous lines of treatment during their whole course of small cell. But we're still seeing pretty good responses to tarlatamab in the CNS. And this was an update from ESMO, looked a little bit further in the phase three trial with survival by chemotherapy-free interval. We can see here, even with the platinum-resistant, tarlatamab offers a large benefit over chemotherapy as well as the platinum-sensitive. Of course, the platinum-resistant does seem to be just a more challenging course to get strong efficacy and a worse prognosis. And then looking at the toxicity, this has really become one of the unique points with tarlatamab. Us in the solid tumor world don't have a lot of experience with bispecifics. We have the melanoma bispecific, but otherwise, this was really the first one that we see in the solid tumor world. So we can see here the grade 3 or higher treatment related occurred in a good number of the patients. And then when we're looking at dose interruption, also in small number of patients, much less so than the chemotherapy. And so CRS and ICANS, that's usually what we're thinking of the most when we think about some of these serious adverse events. So CRS is cytokine release syndrome, and ICANS is neurotoxicity. And so this kind of lays out some of the common symptoms that we see. This is why our patients are hospitalized, at least currently in most of our institutions. And at Duke, what we do is they see us in clinic, they go over to the hospital. From their infusion point, they spend 24 hours in the hospital after they get the tarlatamab infusion. And it's really to look out for CRS and ICANS, which is caused by the tarlatamab and this bispecific really activating the immune system, the release of cytokines like IL-6 and et cetera, causing these sometimes very serious symptoms. Usually what we see is fever, but it can lead to hypotension, oxygen requirement, and neurotoxicity. So this lays out the incidence by treatment cycle, and we can see here with the first two treatments, cycle 1 day 1 and cycle 1 day 8, that's when the majority of CRS happens. And one thing, and that's why we hospitalize these patients so we can make sure if they do need pressors, oxygen requirements, that they are supported and have everything they need. But when we look at ICANS, that actually can happen at almost at any time. That can happen early on. It can also happen well into the course. And so that's something that we just need to make sure we educate our patients and especially their caregivers that if they do notice any confusion, any personality changes, or anything concerning, that they reach out to the oncology team and make sure that we make them aware. So we can guide proper management, including steroids for ICANS, steroids, and or tocilizumab for CRS. This also goes into some of the incidence and severity of treatment-related adverse events over time. So the focus points, of course, is CRS. Of course, that's unique to tarlatamab. We don't see that with chemotherapy. With tarlatamab, we see a little bit of heme-related toxicities, but not at all like chemotherapy. And then again, we see the decreased appetite, taste change right here as really two of the things that I've seen in my practice impact quality of life the most. And unfortunately, we don't have great solutions to overcome this, but um, definitely looking into it and trying to support the patients the best we can through these. A little bit more about CRS dynamics and monitoring. One of the conversations that I think is coming up more and more, I'll talk about this a little bit more with barriers to treatment, but it can be really hard for patients to be monitored for 24 to 48 hours. You know, if they live far away from an academic center, um, if you know there's any challenges with insurance, and so it's really limited how what institutions can offer tarlatamab and what patients have access to receiving tarlatamab. This was a nice study that looked at 68 hours of monitoring versus 48. And importantly, the hospitalization for any grade was not significantly higher in the 6 to 8 hour monitoring. And I think one of the things that we need to make sure some institutions are already doing this in the outpatient setting, even with dose 1 and 2, is that we really provide really good support to the patients and very, very clear instructions, and there's an infrastructure in place. And then when we look at the analysis of treatment-related events and the number of patients, we can see here that there does seem to be a difference, and there's been some real-world data on this too, that in the real-world setting, we see a little bit higher rates of CRS and ICANS. Part of that is, again, these clinical trials, they kind of choose a very overall healthy patient population, not too many comorbidities, a good performance status. As performance status increases, there does seem to be like a correlation between a higher risk of CRS and ICANS. Liver metastases and tumor burden does seem, both from the trial and some real world evidence, to have an impact on CRS. Brain mets doesn't seem like it does to a great extent. There's been some looking into ICANS in particular to see if brain mets did or did not. I feel like the data is a little bit mixed. Kind of small patient populations maybe has an increased risk of ICANS though. And so when we're considering who to do outpatient monitoring or reduce the monitoring to 68 hours versus longer, these are some of the things that I think are being taken into consideration, and we'll have more evidence on as we go along. This just, again, kind of goes into some of the incidents of where we're seeing of ICANS specifically. And so we're seeing here patients with events, pretty low number overall, only 6%. Thankfully, very low serious, more than grade 3. But these are something scary because when it does happen, and if it is serious, then obviously it can lead to severe complications and very rarely, but sometimes even death. And then, as we talked about, the dysgeusia can be a real issue, and I wish we had better solutions for that because it is fairly common. So management, how do we treat? Grading is really important. We need to know, fever versus oxygen requirement versus hypotension with ICANS, thinking about the ICE scoring system, asking the patients the usual orientation questions, having them see their writing technique, if their writing style has changed at all, doing some executive functioning tasks like naming things, etc. We need to make sure that we have the treatments available to them, such as fluids, Tylenol, steroids, and making sure that we hold the tarlatamab until whatever adverse event has resolved itself. Right now, we're still using the ASTCT guidelines. There's been some conversations whether that's the best to translate some of the heme-related drugs to our solid tumor drugs. But for now, this is, I think, what most institutions are using. And this just goes into some of the main things that I've discussed that we use for grading to make sure that we give them the optimal treatment and escalate treatment as needed to include steroids and or tocilizumab. So what's next? A lot of different types of treatments are coming out. We have monoclonal antibodies. We have antibody drug conjugates. You can see some of the targets here. A lot of these were presented recently in the past year at conferences. We have BiTEs like tarlatamab. Tri-specifics are coming out as well. And then on the right, a lot more research has been done into the tumor biology of small cell lung cancer, including, the inflammatory type, PAL2F3, neuroendocrine spectrum of small cell lung cancer. And as I mentioned before, with a lot of these, especially the immune treatments, but also probably with some of the ADCs, it would be really interesting to see, can we better predict who will have a response, who needs escalation, who doesn't, who could be a durable responder? How can we get more people to the durable response? So this is one of the things I think is really interesting coming out more and more in small cell. This is one of my favorite studies that came out recently. I think it's really exciting. This adds tarlatamab to chemotherapy and checkpoint inhibition. In this trial, which was presented at ESMO, it added it after one cycle of chemotherapy and immunotherapy, which kind of makes some sense. As we talked about, a higher tumor burden can cause more CRS, and CRS can be associated with ICANS. And so kind of like debulking them. And sometimes we see patients who get chemotherapy in the hospital. And this kind of allows for that too. So I kind of like that trial design for this, but it adds tarlatamab after that first cycle and then just continues it in the maintenance phase, continues it with the anti-PD-L1. It used both atezo and durva as choices. PFS was significant. So the top two are the checkpoint inhibitors. And we can see a big response here. And then the best overall response in tumor shrinkage, again, really nice tumor shrinkage, and really nice duration of response right here. And this is one of my favorite slides because at 12 months, we see 80% of these people were still alive. And so when we think about the historical value of about 50% of patients at 12 months, this is a huge benefit. And we can see, not surprisingly, I don't know if there's much difference between the atezo and the durva, but I think this is very exciting. This is a phase 1 trial, but I am very eager to see it more commonly used in the phase 2 setting and beyond and see more of the data. But I think this is one of the most exciting things that we've seen recently in small cell. And then when we think about the safety, not too different than what we would expect from everything else that we know about chemotherapy, checkpoint inhibition, and tarlatamab. It's a lot of different modes of treatment. So we kind of have to look out for every type of treatment toxicity. From the chemo, we see heme toxicities. We have to look out for checkpoint inhibitor related adverse events. And then, of course, we're adding to that CRS or ICANS. We can see here treatment related AEs only led to discontinuation in 6% of patients. So pretty low, and there was no deaths in the trial related to the addition of tarlatamab. And then CRS and ICANS were relatively low. So this is the timing. So not surprisingly, again, we see a lot of the heme things up front. And then in the maintenance, very low numbers of grade 3 or higher. The weight decreased is a big one. And unfortunately, that just seems like it goes along with tarlatamab. And then we see again the CRS or ICANS. So very low grade 3 or grade 4. The vast majority of these are grade 1 or grade 2. After cycle 1, very low rates, and after cycle 2, almost non-existent. Nearly no ICANS, just really, really low. So maybe that's because they had the one cycle of chemo. But this is encouraging to see. That doesn't seem like it increases at all the risk of some of these in the frontline setting. So other types of treatments that are coming out, this was presented at World Lung. This is IDXD. This is pretty far along. This was the phase 2 trial right here. You can see here's a B7H3 antibody paired with a deruxtecan payload, topoisomerase. And this was the study design. And really promising efficacy. We know that B7H3 seems to be widely expressed on small cell lung cancer tumor cells. And this was a really nice waterfall plot in patients who were pretty heavily pretreated. We can see second line and third line and above, and both of these groups having really nice responses. Median PFS was 4.9 months, and median overall survival was 10.3 months, which again is a big improvement from what we think, especially with third plus line of settings, don't have many options. Lurbinectedin and then topotecan is not the best tolerated, and usually in the third line, we're looking at survival of maybe 3 or 4 months. And so at 10 months, that's a huge improvement. So this is a really exciting agent. When we look at safety again, not surprisingly, we think of ADCs as like kind of smarter targeted chemotherapy, but at the end of the day, still chemotherapy, and that's really what we're seeing here is most of the chemotherapy side effects. Doesn't seem to have too much unique toxicities related to ADCs. One of the things we always worry about that was nicely discussed in the previous lecture was pneumonitis. We did not see that with IDXD, so that was encouraging. And then other novel ADCs, we can see here at the top a list of a whole bunch of different treatments that have come out very recently. So we have CES6 with the AbbVie was recently presented at World Lung, the B7H3 additional targets in this setting, TROP2, sacituzumab, govitecan has for past year or two have shown some pretty nice data in the refractory setting. And then when we look at the PFS and OS, again, very early trials, but pretty encouraging objective response rates across the board for, heavily pretreated small cell lung cancer, pretty nice movement in progression-free survival. And then, of course, looking at the toxicities, what we would expect from antibody drug conjugates. So one thing that we have to really keep in mind, there's so many new drugs coming out in small cell lung cancer, including tarlatamab and other bispecific agents, soon to be trispecific agents, soon to be more antibody drug conjugates. We need to make sure our patients can have these, can have access to these, and we need to make sure it's as equitable as it can. So I think, access to care and the financial toxicity are things that we as a lung cancer group have to really work towards and make sure that we work towards increasing equitable care. One of the ways that I touched upon that could maybe help with this is outpatient tarlatamab. A handful of academic centers have either already started this or soon will be starting it and actively discussing it. And so this looks like something that could work is kind of like a pill in your pocket approach where they go home with some dexamethasone and then again, very clear patient instructions. I've heard talk about maybe wearing like a tarlatamab bracelet. So if you do go to another ER, like they know what unique drug you're getting, or even like a pink sheet where you have something where if you go to a non-academic center, they know exactly what to do, what to look out for, making sure they have a good number to call. But it's lots of great discussions have been taking place in the past few months to make sure that we can offer novel treatments to as many patients as we possibly can. This was a nice study that was published, again, showing from the data that 6 to 8 hour monitoring does not seem to be to add danger if done in the right patient population and the right setup. And so we can see patients visiting the hospital or ER in cycle one was pretty low in the outpatient setting. So that was nice and can see hospitalization events, ER visits. Could it be because of the patient population that was selected? Maybe, but still very encouraging results. So in conclusion, we know small cell remains very aggressive, difficult to treat. We know that some of these novel therapies offer a lot of hope, really good responses. One of the points I've come up a lot is that durable response, biomarkers are essential. We have so many biomarkers and we've come such a huge way in non-small cell lung cancer. And I think that's where we're headed slowly but surely in small cell lung cancer. And so really knowing from these biomarkers who will respond, how can we treat this unique patient differently, knowing and predicting, do they need something more or not? Are there any biomarkers that can predict who will have toxicities? There's been some data in the heme world and now at Moffitt mainly using prophylactic tocilizumab. If someone we can predict will have really high risk, could that prevent a long hospitalization? And then, of course, what drives resistance? Why do these drugs stop working? Is there anything that we can do or pair it with to help keep the immune system from exhaustion, kind of similar things to what we think about a non-small cell with some of the checkpoint inhibitions. We need even better and more agents after tarlatamab. It seems like tarlatamab will sometime soon-ish be in the front line, most likely. So what do we do after tarlatamab? What's the best sequence of some of these treatments? Making sure that as many people as possible have access to these treatments remains a huge barrier and something that we all have to actively work on. And then, of course, support is key, both emotional support as well as, as I've shown, a lot of these have toxicities that are very real and can have an impact in quality of life. So making sure that we treat the person as a whole and that we rise up and we try to prevent and treat as much of these toxicities as we possibly can. So I think the best is yet to come. So many exciting things coming out. Thank you so much for the invitation to speak. Would love to answer any questions from the audience. I'm sorry I couldn't be there so I could see all of you directly. Would love to chat about anything if there's any comments or questions.
Do we have any questions for Dr. Alder?
I can stop sharing.
Oh, we do have a question.
So I'm curious, is the surface marker anti-DLL3 expressed on any other type of malignancies than small cell, like neuroendocrine carcinoma, for example?
Yeah, it's a really good question. There's been some evidence that large cell neuroendocrine and other types of high-grade neuroendocrine tumors do express it. So some of the more recent trials looking at both tarlatamab and BI's agent obrixtamig are including large cell neuroendocrine especially. But there is some interesting data from like GI, prostate, high-grade neuroendocrine tumors. And it's mainly just kind of case reports at this time, but there does seem like there is some overexpression in those types too. Usually for small cell, we don't even have to test for DLL3, but for some of the other neuroendocrine tumors that are not large cell, it seems like there is some sort of efficacy benefit depending on the extent of overexpression of DLL3. So more to come in those areas.
Yeah. So specifically, the prostate cancer that's known as small cell
Yep.
cancer in the prostate, that a particularly nasty disease,
Yeah.
has that been specifically looked at, the DLL3 expression?
That's a great question. I'm not aware of that specific
Do,
expression rate.
do you have to specifically, is there a aftermarket or a company that specifically measures that, or how does one go about ordering that? Would it show up on next generation sequencing type stuff?
Yeah, it does not show up on next gen sequencing. I've ordered it a couple of times when the tumor histology is just like kind of odd. And so it's like it's some type of like poorly differentiated type of neuroendocrine tumor, but it's not large cell, it's not small cell. It's a send out lab. And so I ask our people to do it as a send out lab. I think it may go to Mayo Clinic, but I'm not exactly sure exactly where it goes. Um, but there is a companion diagnostic that is being used for some of these trials that are requiring it. But for the Delphi trials with small cell, it doesn't require testing.
Hmm. Thank you.
Do we have additional questions?
Just a question about lurbinectedin. Have you identified, or do you know if there's been anything identified that correlates with response to that drug? I have an interesting patient who had a small cell kidney cancer, and I gave that drug to him, and he, responded exceptionally well. And he kind of goes off and on treatment because he doesn't like being on chemo, and doesn't really understand that he's got a chronic disease. But every time he gets it, he responds vigorously, and he was on it for a couple years. And I mean, I've never seen that happen with any of my small cell lung cancer patients, but I'm curious if you've had that experience and if you know of anything that predicts response to that drug.
Yeah, it's a great question. I actually had a conversation with Dr. Misty Shields, and her lab is actually looking at that specific point, and they're excited that they may have found something. But to my knowledge, right now in current literature, no. And I think, biomarkers will be really helpful and knowing like the different subtypes, like, about that patient of yours, I'm sure there's something about it that's unique. And I think small cell itself is not just a broad category anymore, and it does depend on histology, and it does depend on what are the genomic and genetic factors going into the tumor biology. I have had very rarely, but a few patients do seem to have a really durable response to lurbinectidine, and I wish it was easier to predict because that would make Forte a little bit easier to decide, who needs it or who doesn't need it. Um, actually, some of the patients who I think about lurbinectidine a little bit more is if they didn't have a really nice response. To chemotherapy, then I worry a little bit more about adding lurbinectidine. Whereas if the disease had a really nice response, then sometimes I think about adding it to kind of continue that ongoing response. But I think so far there's no data to really help guide us directly.
Any additional questions? All right, seeing none, thank you so much, Dr. Alder.
Yeah, thank you.
So we've come to the end of our event. I want to thank you guys all for your participation and hope that you've enjoyed your time with us. I do have a couple of updates for our upcoming events. Our 16th annual Winter Breast Cancer Symposium is scheduled for February 21st from 7:30 to roughly 2. We're still working on finalizing the agenda, but it will take place at this location. And then our annual mid-year review has already been scheduled for June 27th, and that one will take place over at the La Vista location where we were last year, this year. And then we'll have our speaker series dates posted soon, so be on the lookout for those as well. Thank you guys all for your participation. And again, the link for the continuing education is already on the event website. Enjoy the rest of your weekend.